Welcome to episode 11 of the Pro PA podcast. I'm your host, Prof. G. Today, we're tackling a condition that has transformed medicine over the past few years, COVID-19, caused by the SARS-CoV-2 virus. While this isn't part of every traditional PANCE guide, it's become a critical topic for clinical practice and your exams. Let's break it down with the high-yield essentials. So first, let's talk about the kinder patho. What is COVID-19? COVID-19 is an acute respiratory illness caused by the SARS-CoV-2 virus, a novel coronavirus first identified in 2019. This virus primarily targets the ACE2 receptors in the respiratory tract, and this leads to a range of symptoms from mild respiratory illness to severe acute respiratory distress syndrome, or ARDS. Transmission occurs mainly through respiratory droplets like sneezing, coughing, and it has some potential to have airborne spread in certain settings. So, who does this affect? Well, I can't think of a single human on this planet that was not affected by the COVID 19 pandemic in 2020. Thankfully, since 2020, we've made a lot of medical breakthroughs to get this virus under control. And so anybody can be affected by COVID 19. High risk populations are much more at risk for being infected and having severe infections. And this includes older adults, so greater than 65 years old, individuals, again, with comorbidities like obesity, diabetes, COPD, cardiovascular disease, and immunosuppression, and also pregnant individuals. Transmission is primarily spread via those respiratory droplets, like I mentioned before, like coughing, sneezing, talking, and there is some airborne transmission in poorly ventilated settings. So, how do we present with COVID 19? Well, COVID 19, as we've seen, has a lot of different varieties of presentations. It is a broad spectrum of symptoms, anything from completely asymptomatic all the way into the ARDS and severe respiratory distress. So, if we're talking about mild to moderate disease, the main symptoms we're going to see are fever, chills, fatigue. Most patients have a dry cough, a sore throat, or a little bit of mild shortness of breath. Another key finding in COVID 19 is the loss of taste and smell. So, anosmia and ageusia. And there's also some GI symptoms that present with COVID 19, so nausea, vomiting, diarrhea, since it is a virus. In the more severe disease, we typically see more dyspnea and even hypoxia. So that would be an oxygen saturation less than 94% on room air. And this can lead to ARDS or progress up to this with complete respiratory failure. There's also such a thing called long COVID, which is this post-acute sequela from the initial infection. And this can cause persistent fatigue, cognitive impairment, what they like to term brain fog, and some shortness of breath that can last anywhere from weeks to months after the initial infection. A mnemonic that I can think of for COVID symptoms include the word flows. Flows, okay? Flows. F, fever. L, loss of taste and smell. O, oxygen desaturation. W, weakness. And S, shortness of breath. So, how do we work up COVID 19? Well, we do have some diagnostic testing that we can do at home, and in the clinics. We can use antigen testing. These are rapid tests. They have a little bit of a lower sensitivity, but they are useful for screening if we think we might have a cold versus COVID 19. The gold standard, though, for diagnosing COVID 19 is going to be the PCR testing. It is much more sensitive for detecting COVID 19. Some imaging that we can do if we're a little more concerned would be chest x ray. And the typical chest x ray on a COVID 19 patient would show bilateral infiltrates in severe disease. This is more of an atypical type presentation on the chest x ray. If we got a CT of the chest, it would show ground glass opacities, which is a classic finding for COVID pneumonia. And it's not something we have to do in all of our patients, especially the mild to moderate disease. We're really just going to determine that it is COVID 19 and then monitor. But for the more severe cases, we are going to want to do this more advanced imaging. So, laboratory findings, a lot of these patients do get routine labs along with the infection, especially if they're more severe. We can see some nonspecific inflammatory markers elevated, like CRP. You can also have some elevated ferritin D dimer indicating this inflammation and some sort of coagulation abnormalities. We might also see some lymphopenia, which is a low lymphocyte count. So, management, I feel like, is the area where we've made the most progress over the last 4 years, and it is really severity dependent. So, with mild disease, remember that can be anything from completely asymptomatic to, a little bit of mild symptoms, cough, fever, sore throat, but no severe shortness of breath, none of the other sequelae from it. So, mild disease, we're going to treat in an outpatient fashion. We're going to use mainly supportive care, including hydration, rest, antipyretics, and the preferable antipyretic in COVID 19 has been acetaminophen or Tylenol. We also want to encourage isolation, so trying to keep away from other people to prevent transmission and using masks when appropriate. We can also give the newer antiviral therapies, so we can consider the Paxlovid or the nirmatrelvir ritonavir combination, and these are mainly for patients at high risk of progression to severe disease, and it should be initiated within the first 5 days of symptom onset. Now, for moderate to severe disease, these are going to be our hospitalized patients requiring supplemental oxygen. There are more advanced therapies that we can use on these patients. So, one will be glucocorticoids. So, it is recommended that we give dexamethasone as the glucocorticoid of choice for COVID 19. We usually give around 6 milligrams daily for up to 10 days. And these are in patients that are requiring that supplemental oxygen to kind of reduce that inflammation. The antiviral therapy that we can give for these, we might give the remdesivir, or Paxlovid is more usually used in outpatient settings, but we can consider giving this for hospitalized patients requiring the supplemental oxygen, but not on mechanical ventilation. We also are going to use some supportive measures for our admitted patients. We're going to use a lot of oxygen therapy. We want to maintain that SpO2 greater than 94%. We also need to consider thromboprophylaxis. So we're going to use some anticoagulants. We're going to try to prevent those thromboembolic events that can happen with COVID 19, unless there's some sort of contraindication. So there's also one more category of severity in these COVID 19 patients, and that is the critical disease. These are the patients that are requiring that mechanical ventilation, that are intubated, and they're having to have a machine breathe for them. Again, we're going to continue those glucocorticoids, including dexamethasone, as I mentioned before. We might also add some additional immunomodulatory therapy. This would be like an IL-6 receptor antagonist, like tocilizumab, and this would be in combination with the dexamethasone in patients exhibiting rapid respiratory decompensation. We also have to consider some advanced supportive care like mechanical ventilation strategies and even ECMO for refractory respiratory failure. One thing to note here is that the use of glucocorticoids is not recommended for patients that are not requiring supplemental oxygen because it can be harmful in that group. So, just if you are going to consider giving those glucocorticoids, make sure that you're giving it to the right population of patients. Now, just like any of the other viruses that we have talked about so far, prevention is going to be one of the key points to keeping this disease under control. So, we do have vaccines for COVID 19, and they are highly effective in preventing severe disease, hospitalization, and death. And we also have the booster doses that are recommended to enhance and prolong immunity. My two children were actually in the Pfizer trial and were some of the first kiddos to receive the COVID 19 vaccine in early 2021. And so I'm a big advocate of the vaccines. We can also recommend some non pharmacological measures like mask wearing, hand hygiene, physical distancing, and remain important, and especially in the areas of high transmission. Of course, we want to keep in touch with what the CDC is recommending. Periodically, over the past few years, their recommendations have changed and kind of backed off a bit since we are seeing more mild cases of COVID 19 more recently. So, what's the book med versus the street med? Well, one thing I'll say here is that there is a lot that has changed in the past 4 years from a COVID-19 standpoint. It's probably not something that's going to be showing up on your standardized tests anytime soon because there's such rapid evolvement of therapy and treatment and diagnosis. But I think it is a good opportunity to at least talk about this and be familiar with it and be prepared for the upcoming potential of having these things show up on our exams. So, the BookMed, we're going to follow evidence based guidelines for treatment, including appropriate use of antivirals and immunomodulatory therapies. The street med, I mean, this pandemic really rocked our world on the street, right? We need to be aware of misinformation regarding the unproven treatments. So, we have a lot of patients that were coming in taking all sorts of different types of treatments, both for humans, animals, and alike. And so we just need to be up to date and educate our patients on the importance of vaccination and adherence to the recommended therapies that we prescribe. So, some quick clinical pearls. Early identification of patients at risk for progression to severe disease are crucial in timely intervention. So, we need to really identify who are our at risk populations and get them on the medications that they need to help prevent progression. We also need to monitor for hypoxia. Even patients with mild symptoms can deteriorate rapidly. So, we want to advise for home monitoring of oxygen saturation when it's appropriate. And the third thing I want to mention is we want to avoid routine use of antibiotics. COVID 19 is viral, and antibiotics should only be used if there's a clear indication of bacterial co infection. All right, now that we've talked about a little bit about COVID 19, let's do a couple questions. So, we have a 62-year-old woman with obesity and a well controlled type 2 diabetes who presents with mild fatigue, sore throat, and fever for the past couple days. Her rapid antigen test for COVID 19 is positive, and her oxygen saturation is 97% on room air. She denies any shortness of breath or chest pain. What is the most appropriate treatment? Is it A, dexamethasone, B, Paxlovid, C, remdesivir, or D, supportive care only? I'll give you a sec. If you said B, Paxlovid, you are correct. So Paxlovid has become the first line treatment recommended for high risk patients. So those are patients with diabetes or obesity, asthma, and have mild to moderate COVID 19 to prevent progression to severe disease. And it must be initiated within the first 5 days of symptom onset. Question 2. We have a 40-year-old healthy man presents with fatigue, nasal congestion, and anosmia for the past 3 days. His rapid antigen test for COVID 19 is positive, and his oxygen saturation is 98% on room air. What is the most appropriate management for this patient? Is it A, start dexamethasone, B, prescribe remdesivir? Is it C, supportive care and isolation, or D, order a chest x ray? I'll give you a few secs. If you said C, supportive care and isolation, you are right. So in this case, mild COVID 19 is present without hypoxia, so the treatment is supportive, including hydration, rest, and isolation to prevent transmission. Antivirals and steroids are not indicated for this type of patient. All right, everyone. So I just want to thank you for joining me on today's clinical medicine brief on COVID 19. Whether you're preparing for exams or navigating the real world clinical practice, remember the key principles of severity based management, the hallmark symptoms like loss of taste and smell, and the importance of vaccination for prevention. For more high yield pulmonary content, check out my pulmonary module on YouTube on my channel, Professor G PAC. And if you found this episode helpful, hit follow and turn on notifications so you never miss a new episode. And as always, this is the Pro PA Podcast, where future pros in medicine are made. I'll catch you in the next episode.